I just want to say thanks so much for the opportunity to speak today at the Spring into STEM series that we are doing here in UCL. I feel very fortunate to present the work that I am doing as part of my PhD. And what are we going to look at today? Well, as the title indicates, a tight squeeze, motion management in radiotherapy for patients with abdominal cancers. So today I'm going to cover a little bit about my role. I'm going to discuss radiotherapy and proton beam therapy. I am going to be talking about treating patients with abdominal malignancies. And I'm quite conscious that on the session today, that it is an open session and there may be people with very different backgrounds. We may have some professionals, academics, healthcare professionals, but it might also be the case that we have some public members joining us and some patients. So if any of the information that I say today is quite sensitive or evokes, some emotions or feelings within you today, please do have a look at the 2 QR codes that I've put on the top of the screen here. If you've never used a QR code, they're really simple. Open up your camera, scan the code, and these 2 in particular will lead you to 2 really, really good resources. So one of them is the Cancer Research UK website, which obviously has some excellent resources with regards to cancer diagnosis, treatment options, etc. And the second QR code that I've put up in the top corner of the screen is to the Macmillan website, which of course can provide you with information with regards to treatment support and what you can have in addition on your cancer pathway. And then finally, to finish up the overview, I'm going to get into my research. So first up, a little bit about me. So as Naomi said, I have a little bit of a complicated job role. Half of my week, I am a research and development specialist therapeutic radiographer at UCLH. And I'm really lucky that I work with a fab team there and I work using both photons and proton radiotherapy. For the other half of my week, I'm a Cancer Research UK RadNet PhD student at UCL. And just as Naomi said, that's at our therapeutic radiography PhD school, which is specifically tailored to us as a therapy radiographer. So it's an absolute fantastic opportunity and school to be a part of. And then for a couple of hours a week, I work for the National Radiotherapy Trials Quality Assurance team, who provide quality assurance for national and international trials. So you might be thinking, okay, Amanda's got a very complicated job role, but what is a therapeutic radiographer? So a therapeutic radiographer is an allied health professional, and you may hear the term AHP maybe in the news. In the UK, we have 14 allied health professionals, and they provide a range of diagnostic, technical, therapeutic, and support services connected to healthcare. Specifically looking at therapeutic radiographers and what we do, we have trained to plan and administer radiotherapy. And as a result, we are naturally one of the main healthcare professionals that a patient can meet in their radiotherapy journey. So as I'm sure you can imagine, our work goes beyond planning and administering the treatment, and it really goes to supporting the patient, guiding them through their pathway. And this has led our roles to develop as well. And now in the UK, we have a lot of radiographers in advanced roles, consultant practice, research roles like myself, and running late effects clinics. Finally, I do want to mention that in the UK, we use the term therapeutic radiographer, but we might be lucky enough to have some people in this meeting who are joining us internationally or within Europe. And the term that we would refer to for our profession outside of the UK is radiation therapist or radiotherapist, RTT. So that might be a term that you are more familiar with. So then thinking about what is radiotherapy. So radiotherapy is ionizing radiation, and we would manipulate this radiation so that it can control or kill cancer cells. The most common type of radiotherapy is photon radiotherapy. Photons are bundles of electromagnetic energy, and thinking about it simply, they are a basic unit of nature that makes up all of light. I think that radiotherapy is less well known than other cancer treatments, such as chemotherapy, but there are many ways of delivering it. It can be delivered externally, internally, using injections, or during surgery. And it is actually a treatment that is recommended for over 50% of cancer patients. But unfortunately, we see here in the UK and internationally that it is still underutilized. How is radiotherapy delivered, you might be thinking? Well, I am going to focus on external beam radiotherapy, as this is probably the most common form of radiotherapy that we use. Here you can see a picture of two fantastic colleagues that I have in UCLH, and they are positioning a patient for the radiotherapy. This is the machine here that delivers the radiotherapy. It's a linear accelerator, or for short, you may hear it be called a LINAC. So, how do we actually deliver this treatment? Well, the patient lies on this treatment couch. It's hard, it's flat, it's not comfortable, but we don't want the patient moving. So we have this hard, flat couch, and we also have equipment that we call immobilization devices to put the patient in the treatment position. Once the patient is lying down, we need to get them into their exact radiotherapy position. And this is really, really important. The main way we can do that is using little tattoos on the patient's skin and our laser system. However, there are more and more systems becoming available which we can use to remove these tattoos. And if you're having radiotherapy at a different center, that might be an option for you. So we position the patient, they're ready to go. This is when we have to leave the room as therapeutic radiographers. We cannot be in the treatment room when the ionizing radiation is turned on. We step outside the room, we're watching the patient on the camera at all times, and usually before we deliver the treatment, we'll take an image to make sure that we are really happy that the patient is in the exact position we want them to be for treatment. After we've taken and analyzed this image, we'll deliver the treatment. It takes a couple of minutes. This part of the machine moves around the patient, the head of the machine. The patient will not see or feel anything. And actually, usually what happens is when we walk back into the treatment room, many patients remark on, "Is that it?" So it is quite a non-invasive treatment when we are talking about external beam radiotherapy. The other form of treatment that we can deliver as therapeutic radiographers is proton beam therapy. And just as the name says, they are high energy protons. But what are they? Protons are positively charged subatomic particles found in the nuclei of atoms. They are, for the most part, also administered externally. And the difference between photons and protons is that a photon beam will pass through your body and usually have an exit point, whereas protons can be stopped in tissue without a significant amount of the particles exiting the body. The NHS has commissioned particular treatment sites where there is enough evidence to deliver proton beam therapy. However, there are many, many trials ongoing looking at delivering proton beam therapy in these non-commissioned treatment sites. Here is a little picture of a very, very big machine. Here is one of our gantries at UCLH. And as you can see, the machine is larger than our photon machine. And even behind this piece of equipment, there's about 3 stories worth of machinery that's producing our proton machine. We are really lucky to have this machine at UCLH, and the other NHS centre that has it is the Christie. And for patients, you may be thinking, is it much different to photon beam therapy? Not so much for the patient. The patient lies on the treatment couch. We use immobilization equipment to get them in the same position. We image, and then we deliver treatment. And just like photon beam therapy, there isn't a lot to see or feel. The treatment might take a little bit longer. As I said, it's a big piece of equipment, but it shouldn't take any longer than a couple of minutes. So thinking about then what I do as a therapeutic radiographer in radiotherapy research. So my research is focused on patients with upper abdominal malignancies. I've included a little diagram here to highlight some of the main structures in that region. However, it does not include all of the structures, and those of you maybe with an anatomical background will notice, for example, the image doesn't have the spleen on it and other structures in that region. But hopefully what you can gauge from this picture are some of the main structures that are in the abdominal region, and you may be familiar with them because many of them are concerned with your digestive system. For me, I specifically focus my research on lower esophageal, liver, and pancreatic patients. So a little bit about lower esophageal cancer. You may not be so familiar with the term esophagus, and you may refer to it as your gullet or your food pipe. And what is the purpose of it? Well, the primary function of your esophagus is to transport food entering the mouth, through the throat, and into your stomach. Around 9,300 people are diagnosed with esophageal cancer in the UK each year, and it is the 14th most common cancer in adults. Next, focusing on liver cancer. So, what does your liver do? It processes blood, breaking down the nutrients and chemicals your blood carries. It changes these into forms that are easier for the rest of your body to use, and it also regulates the levels of most chemicals in your body. So it does a lot. With regards to liver cancer, there are two main types. You can be diagnosed with primary liver cancer, and around 6,200 people are diagnosed with this particular cancer in the UK each year. And what I mean by primary liver cancer, this is a cancer that arises in your liver and it starts in your liver. The other type of cancer that you can have diagnosed in your liver is secondary liver cancer. And what happens this is a primary liver cancer arises in a different area of your body and it ends up spreading to the liver. Finally, the final other area that my research focuses on is the pancreas. So your pancreas produces digestive juices and insulin, as well as many other hormones to do with digestion. And around 10,500 people are diagnosed with pancreatic cancer in the UK each year, and it is the 10th most common cancer in the UK. So bringing all of this together with radiotherapy and proton beam therapy, you might be thinking, is radiotherapy a treatment option for these patients? Yes, in terms of photon radiotherapy, we have been delivering photon radiotherapy to lower esophageal cancers, liver cancers, and pancreatic cancers for many years. However, with regards to proton beam therapy, it is not in the UK a commissioned treatment site that we deliver proton beam therapy to. However, there are many investigations and trials that are considering looking at this. So, going deeper then into my particular research within the abdominal region, I'm really lucky to be funded by Cancer Research UK, RadNet City of London, and my research is focused on looking at minimising the motion in abdominal cancers. So you might be thinking from the image I showed you of abdominal cancers, oh yes, I know that area, it's sitting just below the lungs. How do we deliver radiotherapy to this area? And hopefully I'll be able to guide you through this process a little bit more now. I am going to attempt to play this YouTube link. Bear with me and we'll see if it works. So hopefully you can see this open access image here of a patient who is being scanned for their radiotherapy. As you can see, their heart is pumping, their lungs are breathing, they are inhaling and exhaling. And right below this sits the liver. I am going to focus on the liver just for illustrative purposes, but of course the pancreas is moving, the lower esophagus is moving, and the other structures in this region are moving. Because of this movement, radiotherapy can be a little bit tricky to deliver. Not at all impossible, but of course we need to have approaches that we can compensate for this motion. So hopefully this has given you a good idea of what is happening for a patient who is in free breathing with no motion management approach being applied. And we have plenty of approaches that can bring this motion down. I also want to show you guys this particular diagram as well. And again, this is a liver patient, open access. So this patient has consented to their images being shown. And on the first image, you can see the liver in exhale. And we have drawn the outline of the liver on this image. On image B, you can see the patient on inhale, but you can still see the outline of the exhale. And as you can see, there is quite a difference in the position of the liver when the patient is in inhale and when the patient is in exhale. So that's where motion management really, really comes into its own for these patients. So what can we do? What are these motion management approaches that Amanda is talking about? Well, actually, there is a lot, and there has been so much done, especially in the past few years, as we have rolled out more and more treatment options for these patients, and more technical advances have been made. Part of my research is trying to collate all of this information and compare all of these different approaches that we can apply to patients. If you'd like to know a little bit more about my systematic review in motion management approaches for abdominal patients, you can have a look. You can scan this QR code here, and you'll be able to access the protocol for my systematic review. I am looking at different options, including breath hold, tracking, and the topic of the day, compression. So, focusing a little bit more on compression. As you can see here, we have two images of a patient lying down, and this piece of equipment here over their abdomen is the compression device. There are two main types that we use in radiotherapy. We have the paddle, as you can see here, or it might be called an arch. And as you can see, this particular piece of equipment, the pressure is being applied on the patient's abdomen so that their motion of their breathing can be minimized. You can also see here the option of the belt. And here what happens is it's almost like a corset. You wrap it around your patient nice and snugly. And then what we do is we further pump some air into the compression belt so that we can bring the motion down. And that essentially, when the patient is in inhale and exhale, that the different position between their liver is really not so different anymore. So what do we have here in UCLH? So we are really lucky enough that we have a compression belt from our supplier Civco, and we've been using that since about early 2020. And we've treated successfully 150 patients using this compression belt. You might be thinking, well, how has it gone so far? Is it going well? It appears to be a very feasible treatment solution for our patients. Patients manage it extremely well. And what I think helps is we have an appointment with the patient before they have their radiotherapy planning scan, where we can coach, support, and educate our patients about the compression belt. But really, the credit has to go to our patients who tolerate the compression belt really well. And we have found that 89% of our liver patients are able to manage the compression belt. If you are from a radiotherapy background and on this call, you may want to know a little bit more information about how we are finding the compression belt. I'm conscious that today is a public lecture, but I have left a link to our ESTRO presentation, which details how we are finding utilizing the belt. It is very stable, we have very small errors, and we are very happy with its implementation. So do use this QR code if you'd like to know a little bit more about the technicalities of delivering the treatment. But of course, research doesn't stop there. It doesn't stop at knowing how well we do what we are doing. We need to take this the next step further. So part of the research that we are doing in UCLH is, now that we know how stable the setup is, what kind of errors we are getting and what we need to account for, we want to know more about the tumor motion when we are applying the compression belt. And what we are doing in UCLH, and as part of my PhD research, is we are working up a process so that we can scan our patients in compression on the MRI scanner. We are not the first centre to do this, and we hopefully won't be the last, but it is really important that we do this so we know, using our equipment with our patients and our staff, how the motion management equipment is working. And then, of course, a really, really important piece of the puzzle, involving our patients. So those of you who have who notice things may have picked up that I said that 89% of our patients tolerated compression, but that does not reflect how these patients feel about compression, how uncomfortable or comfortable it is, what is the psychological impact of that compression being applied to them. So a really, really important part of our next piece of the puzzle of this research is to do a patient questionnaire. We've been lucky enough to work with our colleagues in the Royal Marsden Hospital to develop a validated questionnaire, and we will be using this with our patients so that we can further involve them and get their opinion and feedback on this piece of equipment. This is really, really important, not just for our centre, but for all centres, because what I'm finding in addition in my systematic review is that there are so little reports in the literature of how patients are managing compression. Finally, then, a nod to the future. So we know that there are going to be some proton beam therapy trials for abdominal patients, but we also need to think about what also might be coming. Once we start to build a better picture of the motion of the tumour internally, do we need to start thinking about how that relates to the external anatomy of the patient? Should we start thinking about more tailored approaches for our patients? Will new motion management equipment become available? Will we require motion management? If AI starts to take over the world, will we have new radiotherapy machines with new capabilities? And most importantly, as we continue to explore all of these ideas and continue to undertake this research, we need to make sure that this information is disseminated wider, and we collaborate with other centres in the UK so that motion management can be adopted in all centres, radiotherapy centres in the UK. That's it from me. I'm conscious I have done a lot of talking. I'm now going to hand over to you guys and see if you have any questions. And of course, I would just like to thank our patients, volunteers, my supervisors, mentors, and the fab staff that I am really, really lucky to work with. Thanks very much.